behind schedule, so without further ado, let me take this opportunity to introduce the first speaker, Dr. Joshua. Oh, I should say that there was a program change. So this first speaker is not Dr. Pardo, who will be speaking tomorrow. We, as is wont to happen at these things get rearranged at the last minute. So our first speaker is Dr. Joshua Katz from the St. Elizabeth's Medical Center in Boston, who was supposed to speak tomorrow, but instead has flip-flopped to speak first in this session. Dr. Pardo's talk will be tomorrow in Dr. Katz's slot. And otherwise, as far as I know, the agenda for this afternoon session is as printed in your material. So, Dr. Katz, thank you.
They were supposed to do something else.
Great. Well, it's a great privilege and pleasure to be here. I really wanted to thank people for accommodating me on this last-minute flip-flop. I was actually told to keep this kind of an up-tempo, upbeat kind of a talk because it's following lunch and everybody's going to have that torpor after eating. That's not going to be so much of a problem. There are people in the audience who are familiar with the elevating effects of steroids and prednisone. I unfortunately had to start taking some because of a herniated disc, and what I found is that in practicing this talk, it's gotten shorter and shorter. And I've actually gotten it down to about 5 minutes, although it sounds like the subtext of a car commercial. So my challenge is actually going to be to try and stretch it out a little bit. So I'm going to be talking about progressive necrotic myelopathy. This is really a devastating progressive illness of the spinal cord. It's been incredibly frustrating for patients and for physicians to treat. And it really is related. It's a cousin of transverse myelitis, Divic disease, and multiple sclerosis, and I'll talk about that relationship. So it's a subject of particular interest to me because it's a fascinating illness, and it also has special personal meaning to me because it's the first project I ever got to work on with my mentor, Dr. Roper, who really taught me a lot about writing papers and how to clinically approach these kind of problems. So, okay, first thing is to get the right button. Oops. Yep, I just hit the space bar, but I hit something before. Let's see. How do I get back? So that hit the mouse. I hit the mouse. Am I the only one who couldn't operate this computer today? All right, thank you. Okay. So my interest in this case grew from several cases that we saw together of patients who had an idiopathic, progressive, very severe myelopathy that was very disabling. And there was no clear description of these cases in the literature. There were descriptions of Divic disease and transverse myelitis, but nothing to just describe the myelopathy. And we began to wonder about the relationship that these cases had to demyelinating disease. So we wanted to look into it further. So what I hope to do in the next 45 minutes, or maybe 20 minutes, depending on how quickly I go through it, is give a brief history of the early literature cases, then give a case example from our own cases, and then I'm going to tell you about what we found about progressive necrotic myelopathy with attention to the clinical features, laboratory and radiologic findings, and the pathology. And hopefully this isn't going to be too redundant from this morning's talks. It has a lot of similarities with transverse myelitis. And then finally I'm going to finish by comparing it to Divic's disease and multiple sclerosis. So when I went back to look at the previous cases that had been reported, what I found is that there were a few seminal articles. The first was really by Foix and Aljounine back in 1926, followed by Greenfield and Turner in 1939. Hoffman had 5 cases that he wrote about in 1955, and then Follis and Netsky were actually the first to coin the phrase progressive necrotic myelopathy in 1970. And these, all these case reports were about patients who had a progressive myelopathy with spinal cord necrosis. And looking back at the time of Foix and Aljounine, actually this is probably a good time to just sort of briefly go off on a minor tangent about Foix and Aljounine disease, because it's referred to as a specific entity, and it's really not so clear to me that it is a distinct clinical entity. There are cases of true AVMs of the cord, dural AV fistulas, and the issue is really compounded by the fact that there are also neovascular changes that are seen in cases of necrotic myelopathy that don't seem to be a true AVM. And going back to the original article by Foy and Alejandrine, it's not clear that this isn't what they're describing. They talk about something called a mesoendovascularitis, which was a thickening of blood vessels around the cord without actual occlusion of these vessels. And, going back to the time of that and Greenfield and Turner, they really lumped all the vascular, non-vascular, and inflammatory cases together. So when you go back and read the original pathologic descriptions, it's really not very clear that they are distinct clinical entities. It's really not until Hoffman described 5 cases that we started to see a distinction between the vascular and non-vascular causes. And he was the first one to really emphasize that pathologically he actually did not find prominent blood vessel changes, as did Greenfield and Turner and Foy and Alejandrine. He found 5 cases that had relatively minor blood vessel changes, and when they were there, he was more apt to attribute it to just neovascular changes around the necrosis. Greenfield and Turner had 3 cases, and 2 of them were probably just true AVMs. So these are the cases that we published. We had 9 patients that we collected from 1981 to 1998, and subsequently we've seen about 3 more. And we looked at patients who had an idiopathic myelopathy with progression over months to years. They had persistent lower motor neuron signs, not just spinal shock after an acute episode, but they really had persistent lower motor neuron signs with evidence of necrosis either by MRI or by pathology. And, of course, these are cases, again, without any of the underlying causes that we've talked about before, no AVMs, trauma, tumor, infection, etc. And then we excluded monophasic or brief duration cases, mostly not to confuse the picture with transverse myelitis cases. So what I want to do is just read through a typical history of one of our patients. And this scale here is sort of a scale of my own making. It's really heavily weighted toward motor symptoms. It's a summed score of weakness, atrophy, areflexia, and in each limb, basically summed over. These are the number of months on the bottom. And so this is a 69-year-old man whose first symptom was urinary hesitancy and incontinence for 9 months. And then he developed abrupt leg weakness, imbalance, and trouble walking. And for about 6 to 8 weeks he fluctuated and improved a little bit, but then the weakness gradually returned. And over the next 7 months, his leg weakness steadily declined, and there was episodic tingling and numbness that appeared in the hands, but that is not going to appear on this chart. And that brings us to about here, where he's 18 months into the illness, and at this point he's really unable to walk. So in a year and a half he's been very seriously disabled and is basically paraplegic. At that point he had a band-like sensation at the level of his navel. There was diminished sensation below the groin, and bowel and bladder sensation were lost. 3 months after that, he had another worsening, where now he develops bilateral arm and hand weakness, followed by slowly evolving intrinsic hand muscle atrophy. So here are the lower motor neuron signs. And he also developed forearm atrophy without fasciculations. At that point, and he had no ankle jerks. So these are more of the lower motor neuron signs that we were talking about. For 3 months, his symptoms really stayed about the same. But then over the next 6 months, his hands became weaker and number, and then he developed atrophy, more profound atrophy of the calf muscles. And so this is a fairly typical case that we see, that people will be static for a period of 3 to 9 months, then have an abrupt worsening, and sort of have what we call a saltatory progression. And that's really well illustrated in a graph that's coming up. I think actually I may have passed that. No, I didn't. Okay. What we found is that the clinical course there were certain characteristic findings. In general, the onset was after age 40, and this contrasts a bit with some of the cases of transverse myelitis and multiple sclerosis. At least in our 9 patients, the average age was somewhat older. It was 59, with the lowest age being 40. The symptoms began with either pain, leg weakness, or urinary incontinence. 3 of our patients had an abrupt onset with severe disability culminating within weeks, and these patients were virtually indistinguishable from transverse myelitis until they went on to have subsequent relapses. The other 6 had a much more indolent progression, more like the patient who I showed you before, with weakness and incontinence that developed over 3 to 9 months before they had their first abrupt worsening. Unfortunately, in all of our cases, it was relentlessly progressive, and patients ended up either quadriplegic or at least paraplegic with sensory deficits in their arms. The most characteristic feature was the saltatory progression with worsenings, abrupt worsenings, every 3 to 9 months, and this was seen in 8 of the 9 patients that we reviewed, and then again in the subsequent cases. And that was really a very characteristic feature. And here's a graph that really illustrates that nicely. These are the 5 patients that we were able to follow for 2 years or more. And in all of them, you can see that there's this sort of stepwise progression, sometimes with minor remissions, but everybody ends up somewhere between 15 and 20 on the scale, which corresponds to paraplegia or quadriplegia once you get above 20. And so there would be periods of quiescence followed by abrupt worsenings, and then maybe a little bit of regression, quiescence again, and then abrupt worsenings, and this was the characteristic pattern that we saw in most of our patients. Other characteristic features, well, same as in transverse myelitis, pain was a very typical feature and a prominent early symptom, often taking the form of burning, radicular-type limb pain, paresthetic pain, dysesthesias. Sometimes there would be less descript trunk and abdomen pain that was just described as a heaviness or a band-like sensation, fairly typical of myelopathies. And then the lower motor neuron signs, which were persistent, with atrophy, areflexia, and limb flaccidity, which really indicated gray matter damage to the cord. And this was corroborated by EMG. When we stuck the segments that were involved on MRI, we did find that it was in fact that there was axon loss. There were fairly characteristic MRI findings. Some of them have been discussed. We found that the combination of early and late findings tended to be fairly specific for cord necrosis. The early findings were extensive swelling and spindle-shaped T2 signal change over a vast longitudinal extent of the cord, not just 1 or 2 segments. Sometimes it was the entire spinal cord from the top of the cervical cord all the way through the thoracic cord. Often it would be the entire cervical or thoracic cord. So really multiple segments, great longitudinal extent, centered really in the middle of the cord as opposed to being on the edges. Sometimes there were focal areas of enhancement. Rarely there were T1 hyperintense areas that suggested focal hemorrhage or petechial hemorrhage. Then the late findings were in these areas where we previously saw swelling. You'd then find severe atrophy or cavitation, sometimes with T1 hypointensity in the center of the cord. And here are some examples of that. I think I just went forward too. Okay. Well, it's not showing up quite that well, but this is actually, these are all T2-weighted sagittal images. Here's the cervical cord, and you can see over virtually the entire extent of the cervical cord, there's this very bright signal right in the middle of the cord with swelling of the cord. And this is the same appearance that you see in de Vick disease. Here's a picture of the thoracic cord, and you can see again throughout the extent of the thoracic cord, there's this T2 signal change, somewhat patchy, but involving most of the cord throughout its length. And again, here's another patient with cervical involvement going all the way down to the thoracic cord. There are areas of focal atrophy because this is now probably 9 months into the course, but there's still extensive signal change. On the left here is a patient who had a little bit of petechial hemorrhage. This is a T1 weighted image. That bright signal corresponds to what we thought was blood in the cord. And then these other 2 images actually demonstrate the late findings with a T2-shaped area of hyperintensity, really almost CSF intensity. So there's a big cavity in the center of the cord. When we look at the axial image, you can see it's CSF intensity. It's almost like a gigantic syrinx that's been hollowed out. And note that it's really involving the center of the cord. It spares the edges of the cord and, to some extent, the dorsal columns. The CSF had fairly consistent but nonspecific findings, so that most of our patients had a moderate elevation of protein between 50 and 100 milligrams per deciliter. There was one patient where it went up as high as 230 and then transiently and then returned to normal. Oligoclonal bands were absent in all of our patients, and then some of our patients had a mild pleocytosis never higher than about 50 white blood cells. Some of our cases had absolutely no cells in the CSF. Visual evoked potentials, when they were done, we had 2 patients where they were normal, and then 2 where they were asymptomatically prolonged. This is very interesting with regard to the relationship to de Vick's. And we only had one of our patients who had a true de Vick's pattern where they developed optic neuritis within about 3 years of developing the myelopathy. cranial MRI was abnormal in one of the 7 patients where it was done, showing white matter lesions that were fairly typical of multiple sclerosis, but the patient was asymptomatic, so they didn't have clinical multiple sclerosis, but they did have the white matter changes. And then we had pathology in another case that didn't get cranial MRI, and we did sections of the brain, and there weren't any demyelinating lesions. So EMG corroborated denervation in 5 of the 6 patients where we did it. And again, when we did their limbs in myotomes that were involved on the MRI, we found that there were reduced CMAPs, fibrillations, and few, if any, fasciculations, in keeping with the fact that they were absent clinically. But this did corroborate that there was gray matter involvement and destruction of the cord. In terms of the pathology, we had one case where we had quite extensive post-mortem pathology. And in that case, it showed coagulative necrosis involving the cervical and thoracic cord throughout the entire length of the cord. And it was non-inflammatory, in keeping with other cases in the literature. There really isn't a whole lot of inflammation to go along with the necrosis. And there was a pencil shape to the necrosis involving the center of the cord that tapered as you went up and went down. The blood vessels in our case were normal, and there was surrounding gliosis. We had 3 patients who had cord biopsies. In one, it just showed gliosis. Another, it showed lymphocytes that were not in a perivascular distribution, as you might find in multiple sclerosis. And then in the third patient, it just showed necrotic tissue with disrupted architecture. And here's an example of the pathology. I'm not sure how well it projects, but you can see the middle of the cord here, right centered at the base of the dorsal columns, is a central pencil-shaped area of necrosis. It's almost liquefied in the center of the cord. There's a little bit of surrounding gliosis, and the remaining tissue around here is actually normal. As you go down to the lower cervical cord, the entire cord's completely wiped out. It's necrotic all the way through, and most of the thoracic cord just look like this. In terms of response to treatment, in our 9 patients, virtually everybody got steroids. Most of them got high-dose intravenous steroids, 250 milligrams of Solumedrol for 5 days or higher. Some had plasma exchange, some with or without Cytoxan. The most that I can say about it is that in all of our patients, if they had remissions, they were temporary, and then they went on to have relapses within 3 to 9 months. So it's really not clear what the steroids were doing. It's not clear if any of these interventions had any useful effect. So we have to say that the overall response to treatment was poor because they had continued relapses. In terms of how to make the diagnosis of progressive necrotic myelopathy, it's difficult unless you observe patients for a long period of time, because there are quite a long list of things on the differential diagnosis. I'm going to put up a slide that's virtually identical to everybody else's today. It shows all these other things in the differential diagnosis. Early on, it can look like transverse myelitis. It can be confused with multiple sclerosis and spinal cord tumors. So you really have to follow people for a long period of time, but it's suggested when there is a transverse myelitis-like picture with a saltatory course, so that patients continue to have relapses and remissions, with prominent pain, evidence of denervation, and persistent lower motor neuron findings. And this combination of early swelling followed by atrophy and cavitation on the MRI, we're really, it's been very well corroborated that does support necrosis of the spinal cord. There was a paper in 1991 by Merrick where they studied 4 patients who had basically this pattern on MRI, and they did biopsies. All of them had necrosis. So that combination of early swelling followed by atrophy and cavitation is reasonably specific for cord necrosis. And again, it's the diagnosis is supported by absent oligoclonal bands, and of course no evidence of an AVM or dural AV fistula on MRI, or if it's done on myelography. And then again, we excluded patients who had a systemic inflammatory illness like Sjogren's or lupus or HIV. And then again, it's somewhat supported by no response to steroids. Those people who did respond well tended to be thought of as more in the MS category. So here's that same differential diagnosis slide that you've been seeing all morning. There are acute and subacute causes, infectious like herpes. It's probably not worth belaboring the point because you've seen this so many times, but at the bottom of the list you can include progressive necrotic myelopathy. Unfortunately, for those patients who develop an acute myelopathy, you'd have to think about it, because over 3 to 9 months, if they were to have relapses, then that's what you might consider, along with DIVIC. And again, it does belong in the chronic category as well, because these patients had symptoms that went out as far as 2, 3, and even 4 years. And it's relatively easy to distinguish it from some of the other ones in this category just based on the MRI appearance. I wish I had something more intelligent to say about the etiology than unknown, but I really don't. At least it's unknown to me at this point. It's very intriguing that there are such profound changes in the spinal cord, both pathologically, radiologically, and clinically, and it's very difficult to get your hands on exactly what the problem is. You know, it seems reasonable to suggest that it could be an immune-mediated problem because of its MS-like behavior with relapses and remissions, and yet the pathology to date, it really does not show any inflammatory changes, so it leads one to wonder. There's no clear response to any of the classic immune therapies either, so it's not very clearly an immune problem, but I still think that that's the leading contender. And, you know, of course, this topic of this category of illnesses is hot now anyway, but that's what I'm leaning toward thinking of it as. You know, it is possible that it's infectious, but I think for the same reason that it doesn't appear to be inflammatory, it seems even less likely that this is a direct infectious pathogen causing this. What is interesting is that the pattern of necrosis that's seen in progressive necrotic myelopathy and in DIVX is really similar to the pattern that's seen with ischemia. If you look at cases of patients with systemic hypotension, they'll develop this central tubular-shaped cavity in their spinal cord with a pencil-shaped tapering at either end, involving sort of what's thought of as a watershed area in the cord. And there is at least one case that I saw recently where they did a three-dimensional reconstruction. It was a Japanese paper, I think in '89, where they had a patient who had an extramedullary cord compression in the mid-thoracic level from a tumor, but they developed a pencil-shaped area of necrosis that extended well above and below the level of the tumor, suggesting that it has something to do with intrapial pressures and venous return that can cause that pattern of necrosis. Now, it's tantalizing to think of this somehow as being a vascular problem in DIVX and progressive necrotic myelopathy, and yet there have never really been any blood vessel abnormalities that are consistently found in those cases. So it's just interesting. And again, it's when those blood vessel changes have been found, it's somewhat confusing that it may just be a neovascular response to the necrosis rather than a true type of malformation. And I think that remains confusing. Well, in comparing progressive necrotic myelopathy to multiple sclerosis, there are some similarities, and they both share the relapsing remitting course, and certainly both can present with a progressive myelopathy. But there are a number of important differences. One is the older age of onset, although we have a limited number of cases, and I think our institution tends to see older patients. Looking at the literature in general, it does seem that the age of onset is older than is typical with multiple sclerosis. The prominent early pain is not typical of multiple sclerosis, and the necrosis with prominent lower motor neuron signs, well, it can happen with multiple sclerosis, is certainly not typical. Again, the absent oligoclonal bands, that's uniformly been true for all of the cases, and again, that's not like multiple sclerosis. The normal cranial MRI, except in one patient, the prominent gray matter involvement, and non-inflammatory pathology. You know, we've never found these perivascular lymphocytic infiltrates that you see in multiple sclerosis, and the fact that it doesn't respond to treatment. All of these things are things that really, in my mind, set it apart from multiple sclerosis and push it over as being a separate category of illness, perhaps. Before I compare it to DIVX neuromyelitis optica, it's worth saying that first, it really depends on how you want to define neuromyelitis optica, because that's a pattern that you do see in multiple sclerosis. And if you look at the pathology of neuromyelitis optica, there are cases where clearly there are perivenous lymphocytes, it's demyelinating, and it's not a necrotic lesion, and these patients also have other cerebral lesions that look like multiple sclerosis. So if you include that category in what you call DIVX, it really clouds the picture. The first cases were described by Eugene DeVick and his student, F. Galt, in 1894, and we compared our cases to DIVX. It was written by these excellent papers, one by Dr. Mandler, who's here today, and other by Dr. O'Riordan. Dr. Mandler, I don't want to describe the paper that he's written. He's sitting right there, but he described 8 cases, and all had either a progressive or relapsing course in his patients. The interesting difference is that his patients all developed optic neuritis generally within about 2 years of developing the myelopathy, sometimes before. O'Riordan described 12 cases, and he felt that the criteria for DeVix should only include cases where there's a severe transverse myelitis with no involvement beyond the spinal cord, except for optic neuritis, of course. And he would accept patients that either had a monophasic or a multiphasic course. And he was the one, well, he wasn't the one, but he came down feeling that DeVix and multiple sclerosis are distinguishable and probably able to be parsed out into two separate categories. So with that in mind, when I compare progressive necrotic myelopathy to DeVix, when I use Mandler's and O'Riordan's cases, there are really very many more similarities than there are differences, and for the most part it ends up being, looks like the same thing. The myelopathic signs and symptoms are virtually identical. The age of onset being somewhat older than multiple sclerosis is something that's been true of both cases. The MRI appearance, again, is identical with this very long longitudinal extent of the cord being involved. The CSF profile with absent oligoclonal bands, and again, though nonspecific, it does match up perfectly with the other cases of DeVix. The poor response to treatment, I'm sorry to say, is a factor that it does share. And the pathology, which is the non-inflammatory necrosis, usually without prominent vascular changes, is identical to those that have been found in DeVix. Again, with the only important difference being the optic neuritis, that our cases didn't really have optic neuritis, although I would say there was one case that did, and really did match the pattern for DeVix, and there were two patients with prolonged VERs, suggesting that there are more similarities than differences, and it probably is the same thing, I think. And again, some of the cases of DeVix are monosymptomatic, and all of ours were progressive. Those were the only important differences. So it ended up taking me about 40 minutes to make this little triangle in the middle, and after all of that, you still can't read it. So what that should say there is, let's see if I can get close enough, the MRI, clinical features, pathology, and response to treatment. And what I'm trying to get at here is that if you take all comers for neuromyelitis optica, and you could probably include transverse myelitis up here, when you look at them, there's certainly a spectrum with DeVix and progressive necrotic myelopathy on one side and demyelinating inflammatory disease, ADEM, and multiple sclerosis, maybe somewhere on the other side. I don't know, perhaps ADEM belongs more in the middle, that's where I put it. And if you have this wedge of clinical symptoms and signs, pathology, CSF, and MRI, it does start to cleave this apart reasonably cleanly into two groups. Certainly there's blurriness at the edges, but you end up having multiple sclerosis more on one side and DeVix and progressive necrotic myelopathy more on the other. And don't take this too far. I'm not suggesting that this is actually the difference, but I just hypothesize perhaps that these are manifestations of the same underlying process, one directed against myelin-based antigens, the other perhaps directed against neuronal or axonal-based antigens. It's just a hypothesis that's really not supported yet, although I'd be interested to see what the other talks coming up have to say about that. And I think with that, I'm actually done. I've exceeded my my last run through. I think I'm just going to conclude by saying that progressive necrotic myelopathy really can be thought of as a form fruste of DeVix. It's a very serious and frustratingly difficult to treat neurological problem with a very severe myelopathy that progresses over months to years. And while we don't have any treatments for it at the moment, I'm hoping that with further research and looking into it, we'll be able to find out, get some answers as to what's causing it. We still don't really know what the underlying causes are, and it's very frustrating, but hopefully we'll make some headway. Thank you.